Okay, I'm now recording. Thank you very much. Okay, so here we go. So this week one tutorial, there is a bit of review of the lecture here, and I know that it may be a little bit, ho-hum for a lot of you, but it's just so really, really important for you to understand what is happening when you are doing a blood group, okay? Because it's when you're talking about forward groups and reverse groups, you can get really confused if you're not stopping and thinking about what it is that you're actually doing. And that's really important for you to do. So there's some review questions here, which usually if I was on site, I would have put I would have been in the lecture hall 5 or 10 minutes beforehand, and the people who were there would have done these questions. But what I suggest that you do is, if you have time, to go through these review questions before you go into your practicum, which of course is no good for the people who are going straight into the prac from the tute, but you may find time during your prac session where you can do these questions, or in fact do them when you go home. Unlike Haematology 2 and Haematology 1, we don't have a weekly MCQ, and I know a lot of you really enjoy that weekly MCQ. So what I might do is devise one each week, which is really just for your revision. It won't have a weighting to it, but for those who found it quite useful to, read through their notes and do the weekly MCQ, then it might be an additional help to your learning. So you can see that for the learning, for this module, we have a number of learning objectives, and what this tutorial focuses on is learning objective 8. So it's a bit of a pre-lab as to what you're going to be doing when you go into the lab, and hopefully you've all looked at the videos that has very kindly made for me. So Sam break spent some time over the break updating these videos for me, so that you have got a constant reminder that you can go and have a look at each week, and certainly before your tests and your exams. When you get into the laboratory, you will find that transfusion is for people who like certainty. It is for people who like structure. So if you're a creative type and you like to, you're a little bit lateral in your thinking, you may find transfusion a bit of a trudge. But for those of you who, like me, like structure and like order, then transfusion science is the topic for you, because it's really, really important for you to follow these rules. And the reason for this is because, as we keep saying to you, this is an area where if you make a mistake, it can have really negative effects on the patient. And so one of the ways that has been found to reduce error is by doing the same thing over and over again. Okay, so you need to follow these laboratory rules, and it's really, really important that you do. So you need to label the tubes correctly. I know sometimes it's a pain, but when you get to the stage where you are testing more than one patient, it's really, really important that the tubes are labelled correctly so that you can tell the difference between your patients, and so you don't get your results mixed up. Okay, really important to record all your agglutination results one at a time. Look at your tube, decide on the result, write it on your form, put that tube down, look at the next tube, decide your result, write it on the recording sheet, put that tube down. That's really, really important. And again, some rules about quality control. So you'll be learning all about how to set up your quality control today. And every time you come into the laboratory, which this semester is only about 6 or 7 times, but every time you come in, you will be expected to do your quality control. Okay, so usually once you get up to speed with it, it should only take you about 10 minutes. And I don't know how Melina will organise the prac sessions. It may be that she can get you into the lab a little bit earlier each time so that you can do your QC, you know, you can set up your workstation and do your QC before the prac actually starts. Okay, so just a little bit about the different laboratory typing techniques. So you can see here that there are a number of different techniques that can be used, and depending on the size of the laboratory and depending on the financial capability of the organisation for which you're working for as to what sort of techniques are used. Most laboratories these days use this column agglutination technology, and this is because this is the technology is most easily transferable to automation. So all of the techniques that you're actually learning in your practical sessions are what we call the manual techniques, and they have all been transferred onto automated analyzers, just as in hematology, just as in clinical biochemistry, and more so in microbiology. But you still need to know the basics. You still need to understand what the machine is doing so that you can interpret the results that the machine spits out. So it's really important. And as I think I've said before, sometimes the machines aren't as clever as they think they are, and we need to go back to the tube techniques just to further investigate, or when the analyzers break down, or, you know, for many reasons. So you still do need to know your tube technique. Steve Tristram was on a visit to Vietnam last year or the year before, I think, and he was most impressed when he went into one of the laboratories there, and in their transfusion science lab, they were still actually using the tile technique. So those of you who did Intro to Medlab Sciences in first year with Jeff Beckett, in the later stages of that unit, you had a week on introducing you to transfusion science, and you actually would have done some ABO blood grouping using tiles. So many of you will have already experienced this technique. But in the laboratory for this semester, you'll be doing the tube technique, which is what you're seeing here. And the other developing field is direct detection of genotypes. So this is very much in the research laboratories, or in the laboratories where we have reference laboratories. So we have reference laboratories in Australia, and the U-Butte big reference laboratory is in the UK. And so when we get unusual results, unusual blood groups, unusual antibodies that we really have trouble identifying, or patients who have, usually they're patients who have a mixture of antibodies, or perhaps they may have a subgroup, so an ABO subgroup that needs to be properly determined, then we will send those samples off to a reference laboratory along with all of our paperwork, and we leave it up to the experts to sort out for us. And often they use the DNA detection of the genotype. So just as a reminder to you, when you are doing your ABO blood grouping today, you will be doing a forward group and you will be doing a reverse group. The reason we call it the forward group is because we are actually detecting the antigens on the patient cells and on the donor cells. So it is those antigens, it is the presence or absence of those antigens that determines the patient's blood group. And so that's why it's called the forward group, because we are directly detecting those antigens. So when you go into the laboratory, you will so you use patient or donor red cells, as you can see there, but you don't use them direct. You know, you don't use them straight from a blood sample. They need to be washed and they need to be converted into a solution of 3 to 5% of cells. Now, Melina will have done this for you today. Usually, again, under normal circumstances, we would actually have you making these solutions yourself, just so you know what goes into doing it. These solutions are 3 to 5% in buffered normal saline, and we always abbreviate that to BNS. So anytime you see BNS or NBS for that reason, for that case, it's always normal saline. So it's buffered normal saline. The antisera that we use is monoclonal antisera. So there is only anti-A antibodies in the anti-A antisera, and that is coloured blue, and there is only anti-B antibody in the anti-B antisera, and that is always coloured yellow, regardless of the company that makes it. And so this is, so when you have a look in your blood tubes when you're grouping, you can actually see the blue colour, you can see the yellow colour. So it's much easier for you to, even though you have properly labelled your tubes with the patient's initials and the last two numbers of their date of birth or their unit record number, you can, it's a double check so that you know that this tube has anti-A antisera in it and this tube has anti-B antisera in it. And so you can see that with our forward groups, blood group A, we're looking to detect the A antigen on the red cells, and so we would expect the A antigen on the red cells to react with our anti-A antisera, and we would expect no agglutination. Remember, reaction means agglutination. We would expect no agglutination when we reacted our blood group A cells with our anti-B. And so when you get this sort of a pattern in your reactions, you can be confident that your person is blood group A. Similarly, with blood group B, we are in the forward group, we are detecting the antigens on the red cells. Blood group B have B antigens on the red cells, and so blood group B is only going to react with our anti-B antisera. So this pattern tells you that you have a blood group B. Similarly, blood group AB, because you have both the A and the B antigen on the red cells, will react with both. And so this pattern tells you that your patient is blood group AB. And blood group O, finally, remember the O stands for 0 because there are neither A nor B antigens on the patient's red blood cells or the donor's red blood cells. And so because those antigens are absent, there is nothing there to agglutinate, to be agglutinated by our anti-A antisera or our anti-B antisera. Okay, has anybody got any questions about that? Because that's really, really important. Excellent. We only ever do a reverse group check when we are determining the ABO blood group of our patients. Further on in the semester, in about week 4, you learn about other blood groups and you start to, and in fact in week 4, we really start learning about other blood groups. And these other blood groups come into play when we find that a patient, when we are screening their plasma for any unexpected antibodies. These unexpected antibodies are usually to the other blood groups because we expect to have antibodies to our ABO blood groups. And why is that? Can anybody tell me? Why do we expect to have antibodies with our ABO blood groups?
They are naturally occurring antibodies.
Beautiful. And what does that mean?
Without prior exposure, they just are developed at 6 months old.
Beautiful. Well done, Z. So we expect to see them. We don't expect to see antibodies with many of the other blood groups because the antibodies that are formed in most of the other clinically significant blood groups are IgG antibodies. And so what's the difference between our IgM antibodies and our IgG antibodies in the transfusion science context?
A and B are group M and O is group G.
Nearly. If we think about, remember where we briefly mentioned naturally occurring antibodies and immune antibodies? So Z has already said that our naturally occurring antibodies are IgM antibodies, which is what the ABO blood group antibodies is, and our immune antibodies are IgG antibodies, and therefore they need a prior exposure to be to occur. And so they're usually not there, okay, unless the person has been exposed to the corresponding antigen. And so that's why we only bother doing a reverse group with our ABO blood groups, because they are really the only clinically significant antibodies that have these that are naturally occurring. Does that make sense to everybody? So we do a forward group for lots of different blood groups, but we only do the reverse group for our ABO blood groups. And this is really the main reason we do that, is to check and make sure that we haven't made a mistake with our forward grouping. Okay? Because again, it's really, really important that we get the ABO blood group right. So here we go, a group A person. Now remember, this is now the serum or the plasma from the group A person. These days in laboratories, plasma is used more than serum, although I think harmoning refers to serum rather than plasma. So we've got our blood group A person. So remember, we have antibodies to the antigens that we lack. Blood group A people have A antigen on their cells. Antigens are grounded in the cell membrane. So A antigen is on the cells and the antibody floats in the plasma. And so group A people do not have B antigen on their red cells, so we would expect to see anti-B in their plasma, and therefore the group A plasma is going to react with our known reagent B cells. Okay. Conversely, group B people do not have A antigen grounded in their red cell membrane, so we would expect them to have anti-A antibody swimming in their plasma. So remember that the anti-A that we normally find will react with the A1 cells, and they also react with A0 cells as well. So it's just A1 cells that we have in our reagent. Patients who have both the A and the B antigen on their red cells will have neither antibody in their plasma, so we expect no reaction with our reagent red cells that we know the blood group of. And finally, group O have neither A antigen or B antigen on their red cells. Therefore, we would expect to find both anti-A, anti-B, and anti-AB in their plasma. Okay, so we would expect a reaction with both our A cells and our B cells, and these are the patterns that you would expect. It's called the reverse group because we get the reverse reactions to our forward group. And if I can make it go back. Okay, so just looking at group A. In group A, we have a reaction with the anti-A, but not with the anti-B. Whereas in the reverse reaction, we have no reaction with the A cells, but we have a reaction with the B cells. So that's why it's called the reverse group, because we're getting the opposite reactions. Does that make sense to everybody? It's really, really important that every time you do an ABO blood group, and you will be doing it every time you're in the laboratory from now on, and the people online will be interpreting the results every week from now on. It's really important that when you are adding your reagents, that you are thinking, okay, this patient sample, what is it on this patient sample I'm trying to detect? How is this reagent that I'm adding going to detect it? Really, really important. The other thing that you will come across, not so much, well, yes, it is with the ABO blood groups, but more so with other blood groups where the antibodies may not react quite as strongly as the ABO blood groups do. And this is your interpretation scheme for the level of agglutination that you see. Usually with our ABO blood groups, this is the level of agglutination that we see. And this is one solid agglutinate or a fairly solid agglutinate with just a few particles coming off. We score this as either a 4+ or a 12. Remember, there are two different scoring systems and you are expected to be able to use both. The reason there are two scoring systems is because this scoring system here, we usually go 0, 5, 8, 10, 12. That's more used with tube technique, whereas the 0, weak, 1, 2, 3, 4 is used with the column agglutination technology, so with the automated techniques. So you do need to be conversant with both. Sometimes we will get a weaker reaction, particularly with the group O person and the anti-B, because there tend to be less, I think it's just a lesser concentration in some group O people. So sometimes you might get a score of 10. And of course, this also depends on how hard you shake your tubes. Because as Sam showed in the video on strength of agglutination, even if you start off with a 12, with a solid agglutinate, you can end up with nothing because you can shake it away. So it's really important that you don't do that. So it's very gentle with your agglutination reading. If you haven't seen that that video yet, I strongly suggest that you have a look at it. So this is just a scoring chart here. So this is putting into words what those images were, and you need to remember, I like you to be able to do that, don't I? I like you to be able to describe something as well as being able to draw it and make an image of it. Okay, so just very quickly now, I'd like you to put your notes away and have a go at filling in the forward and reverse grouping patterns. I think you did this pretty well the other day, so I'll give you a minute to do it. Okay, so hopefully you were able to do that without referring to your notes, and hopefully you were able to do it pretty quickly. Remember, when there is no reaction, we use a 0, not a minus. And as I said in the lecture on Monday, if there is a minus in your prac exam, or even if we ask in the theory exam, then you will be marked down for it. It's very, very important that you use numerals. Okay, so remember, we've got the two scoring systems that we use, the 4 or the 12, and this is what we would usually expect to see. You can see down here for the group O that I've actually put in that it's slightly weaker, because sometimes it does be slightly weaker. Often you'll get in a group AB, the reaction with the anti-B might be a little bit weaker too, and that's because there are more A antigen sites on a group AB than there are B antigen sites. So sometimes that is a little bit weaker because our reagent anti-B doesn't have as many B antigen sites to lock onto. If anybody had any trouble filling in this chart, or if you're still a little bit confused about how to do it, please contact me, send me an email, and I'll run you through it. Okay, so make sure that you've got it down pat, or ask Melina in the prac. She'll help you too. Okay, in your prac book, I think it's on page 8. You have got examples of how to fill in or how to record your results on your transfusion worksheets. So you will be expected to fill in these worksheets whether you are face-to-face in the laboratory or whether you are working online. So each week I'll put these worksheets, a link to the worksheets for you so that you can download them and use them each week. Those of you who are going to the face-to-face sessions, you will end up with a lot of loose paper. You may recall that in Haematology 2, you were given a red plastic folder in which to keep any loose sheets. If you've still got that red plastic folder, what I suggest you do is to remove your Haematology 2 prac notes from it and use it to collect your transfusion science notes together, and make sure that you have them with you whenever you're doing a prac session, so that you can refer to them. Of course, your electronic ones are easy because you can keep them in a folder on your computer. And so you can see here that you put your name at the top. So you use a new worksheet every prac session. You may use more than one worksheet in a prac session, so you need to make sure that you put the date on them so that you know. So, so we can see here, don't worry too about this bit. So even when we do get to the cross-match stage, you'll see that you still need to do a blood group on your patient. So you write your patient's name in full here, and you write either their unit record number, that's what the UR or URN stands for. So that's the number that people are given when they go into hospital. So every time they go into hospital, any of their clinical notes can be collated and collected and kept under that unit record number. Why do you think we give them a number and not just a name? Why are people given a number?
Patient confidentiality.
That's one thing. That's a very good thing. Yes, patient confidentiality. That's really, really important. What else? I can hear it bloop. So what have I got? Yes, exactly. There are about 7 billion Smiths. Well done, Nikki. So it's very important because names can be repeated. So it's really important. So it's much easier to give somebody a unique number than it is to give them a unique name, although I think some parents try very hard to do that. So here we go. Here's our forward grouping here. So remember, we had our patient cells with our anti-A. We mix the samples together, spin them down in our centrifuge, and then we read them one at a time and write the result one at a time. And so we can see here that we've got a very strong reaction between our patient cells and our anti-A, and no reaction with our patient cells and our anti-B. You also do an RH-D group because the RH blood grouping system is the second most important after the ABO blood grouping system. Does anybody know why? The D antigen in particular.
Is it
Yes.
got something to do with the HDFN?
It does indeed, Jordan. Well done. So it's hemolytic disease of the fetus newborn. And this was particularly important in Western countries. It's not so much of an issue in Asian countries. In fact, there are other issues with other RH and other blood group antibodies, hemolytic disease, fetus and newborn in other countries. But it's very important in Australia because the anti-D is an IgG antibody which can cross the placenta and attack baby's red cells if the baby happens to have inherited the D antigen from the father. So it is important also that we record the presence of the or absence of the D antigen on the blood cells. So that's our forward group. So from our forward group, we can be fairly certain that we have a blood group A, Rhd positive. Just as a check, we do a reverse group. And so this is where we mix Robert Smith's plasma with our known reagent A cells and in another tube with our known reagent B cells. And we get the reverse reaction that we would expect. Okay, see that? So because the A antigen is present on the red cells, there is no anti-A in the plasma. Because there is no B antigen on the red cells, there is anti-B in the plasma, which is reacting with the B cells. So that we can be fairly certain that Robert Smith is group A Rhd positive, and that's how we write it on the form. There's examples for all of these things, for your blood grouping, for your antibody screen, for your cross-match in your PrAC method book. So for the rest of the lecture, we're going to have a look at ABO blood group discrepancies. Now, unfortunately, you won't be doing these in the lab today because we thought it most important for you to get just standard ABO blood grouping down pat. But we will, next time you go into the laboratory in week 3, we will have an ABO discrepancy there for you. So again, you'll have to remember to bring your, keep your PrAC notes with you and next to you when you're doing this online so that you can help to work out where the discrepancy and what you need to do with it. So we call these ABO blood group discrepancies or ABO blood group abnormalities because we're picking up an unexpected or an abnormal reaction. And so this is when something happens in our forward group. So we don't get this pattern. Something happens that disrupts this pattern. And so that's when we call it a discrepancy. Okay, so when you're looking at your ABO blood grouping reactions, you should always get at least a 10 with your agglutination reaction. Any less than 10 is considered a discrepancy. Okay, and we'll see why in a minute. And so whenever you get any unexpected reaction in your ABO grouping, the first thing you need to do is to check the sample. Why do you think you need to check the sample?
For labels and see if it meets the quality requirement.
Beautiful, well done, Basim. Yes, so you need to make sure that you've checked the label. Yes, Nikki, to make sure it's the right Smith. So yes, to make sure that you're actually testing the patient that you think you are testing, particularly in the transfusion labs on campus, because Melina will have already separated the blood cells from the blood plasma. So you have to be very careful that you are testing the same blood cells with the same blood plasma. So you're testing Robert Smith 1, 2, 3, 4, 5, 6 blood cells, and you're testing Robert Smith 1, 2, 3, 4, 5, 6 plasma. Okay, so that you haven't got them mixed up. You also need to check the patient history to see if this patient has had an unexpected result in the past. And then the next thing you do is you repeat your blood grouping to make sure that you haven't made a mistake, okay? Because the most common source of error with transfusion reactions, adverse transfusion reactions, is clerical error. And that means getting things mixed up, or transcription errors, which is where you're getting things mixed up when you're writing them on your results sheet. Hence, writing down one result at a time, okay? Hence, checking the sample to make sure that you're testing the correct patient. And as we will see, sometimes you need to wash the patient red cells. So if this was in a laboratory, in a working laboratory, you would just be given a sample of patient's blood and you would have to separate the cells from the plasma. And sometimes, particularly when we're in a hurry, what we do is we make the 3 to 5% suspension using the patient's own plasma. And so if the patient's got some sort of a protein abnormality, or if they've got an autoantibody, or a lot of other things that might be present in the plasma, that might be interfering with the blood group. And so that's when you wash your patient cells and you make up your suspension in your buffered normal saline. When you're in the laboratory here, your cells have already been washed and prepared in the buffered normal saline, thanks to Melina. Sometimes, if you think that there may be an error, particularly if a patient's unexpected reaction doesn't match what you've had before, because whenever a patient comes in for surgery or for any reason that they may think that they may need blood transfused, what we call a group and hold is done. So that is, we do a blood group on the patient, and then we do an antibody screen to make sure that they don't have any unexpected antibodies in their plasma. So that's called a group and hold or a group and screen. And so patients usually have quite long records about, and every time they come in, they have their blood group checked. And so if there is a discrepancy with the patient history, or if there's just some sort of an abnormality with the sample, then it's a good idea to get a new sample, particularly if it's been taken from a cannula or central venous line, which is often washed with, it's got other drugs and other chemicals in it that might be interfering. What do you think we do in an emergency if we get an unexpected reaction to an ABO blood grouping? Can anybody think what you'd do?
We stop the transfusion.
You'd stop the transfusion. So what if a transfusion hasn't been started yet, Bassem, and they're saying, we need blood, we need blood, we need blood, this person's bleeding out, we need blood? Has anybody heard of the term universal donor? Give them own egg. Beautiful. Yes, that's what we do. Okay, so we give them ORHD negative blood, and often you'll find in accident and emergency departments or Department of Emergency Medicine, and also up near theatre, that they will actually have a monitored fridge, so monitored for temperature, where they will keep a couple of units of group O negative packed red cells. So that's what happens in an emergency. Okay, so there are 4 ABO group discrepancies, and you need to know what all 4 of them are, and you need to know what they are. So what a group 1 discrepancy is, and you need to be able to give me examples of that discrepancy. Okay, so we've been talking about when we get abnormal reactions. So these are all classed as blood group discrepancies, and there are 4 different classes. The first one, which is the most common one, is where we have weak or missing antibodies in the reverse group. Okay, so our forward group, so you can see here, what would we type this person as, just looking at that forward group? So we have no reaction with our patient cells and our anti-A antisera, and we have no reaction with our patient cells and our anti-B antisera. So just looking at that forward group, what is the group of our patient? Try again, Meg. So remember, what we're doing here is we're detecting the antigens that are on the red cells. And we can't find any A antigen and we can't find any B antigen. Beautiful. It's actually group O. And see, this is where you can get, it's very easy to get confused, which is why I really push this. And you've got to remember, okay, what is in this tube here? We have our reagent anti-A and we have our patient cells. What is it that the reagent anti-A is detecting? It's detecting if there is any A antigen on the red cells. Our reagent anti-B is detecting if there is any B antigen on the red cells. There is no reaction with the anti-A, so there is no A antigen. There is no reaction with the anti-B, therefore there is no B antigen. When we don't have the A or the B antigen, the group is group O. Okay, does that make sense? So because we don't have the A antigen or the B antigen on the red cells, we would expect in a group O person to have anti-A and anti-B in their plasma. But in this case, the anti-A is absent because we don't have any reaction between the anti-A and our reagent A1 cells. We don't have any reaction when we mix the patient's plasma that should have anti-B in it with our B cells. Okay, so this is a case where we have missing antibodies. Okay. So we find weak or missing antibodies in newborns. So why do we find them in newborns? I think Z already answered this a little earlier.
Until 6 months, they are not formed yet, some antibodies.
Lovely, thank you. So in newborns, the immune system is still too new, particularly the adaptive immune system. The innate immune system works, but the adaptive immune system doesn't. It takes a little while to gear up. And so we don't have any antibodies present or very, very low concentrations of antibodies present in the newborn plasma, and they are usually from the mother, particularly if the newborn is being breastfed. We also don't have it in older adults, and that's just because in older adults, everything ages, everything starts to break down, including the immune system. Okay, and so we often have reduced concentrations of our ABO antibodies in older adults. So we're looking at people probably more in their 70s and above. People with leukemia, particularly lymphocytic leukemias. And why lymphocytic leukemias?
They produce the antibodies?
That's right. So it's our lymphocytes that produce the antibodies, isn't it? So if our lymphocytes aren't working properly, so that's either leukemia or lymphoma, if they're not working properly, then high likelihood that the antibodies aren't being made, and so we get lower concentrations. Similarly, in any immunosuppressive drugs or any sort of an immunodeficiency, suppresses the immune system, suppresses our B cells, suppresses antibody production. Bone marrow transplants can also, if they're not the same group, can also cause this. Bassem, you had your hand raised?
Sorry about that, yeah.
That's okay, that's fine. Okay, so also if somebody has had in an emergency, perhaps they're, you know, so this doesn't just happen with group O people, okay? This can happen with any blood group, apart from group AB because they don't have antibodies in their plasma anyway. This can happen, so say, you know, you had a group A person who was, you know, had lots of group O blood post transfusion, then they might have a reduction in their or abnormality in their group discrepancy as well. Although having said that, with a group A person being given group O, it's not actually a group 1 discrepancy, so forget that. That comes later. So how we resolve this is usually what we do, because we're trying to look for antibodies here, you can increase the concentration of the cells and your plasma here, mainly increasing the concentration of your plasma, because if you've only got a few antibodies there, by adding more plasma, you're making it easier for the antibodies there to attach onto the cells. But the other thing is that you can cool it to 4 degrees. Extend the incubation and cool it to 4 degrees. Why is that important? Why do we cool it to 4 degrees and not just leave it at room temperature? Because we do all
To
of
keep,
our... Go, Basim.
do we keep them from denaturing or breaking down the antibodies?
Not so much denaturing or breaking down. It's a good thought, though. Lovely, Amelia. That's correct. So IgM works best at 4 degrees. Okay, so remember we do our ABO blood grouping at room temperature because IgM prefers the cooler conditions, but their optimal temperature for reaction is actually 4 degrees Celsius. So if you find that you do have a weak reverse reaction or a weak forward reaction, which is our group 2 discrepancy that we'll look at in a minute, what you can do is put your samples in the fridge for 5 to 10 minutes, very quickly spin them down in your centrifuge and read them straight away while they're still nice and cold, and you should enhance any reaction that's there. Okay. Now I notice that we're running out of time a bit here, so we'll just go through these other discrepancies, and you will be answering activity 4 in your prac notes this week is all about the group discrepancies, so you will be revisiting these. Okay, so the information is all here, and you'll be revisiting them in the prac with activity 4. So group 2, as I said, is weak or missing antigens. These are fairly uncommon, but they can happen. And they're associated with unexpected reactions in the forward group due to weakly reacting or missing antigens. Okay, so group 1 discrepancies are weak or missing antibodies in the reverse group, whereas group 2 is weak or missing antigens in the forward group. Okay, so again, the most common time that we see this is in people who have leukemia, or in fact, people who have had transfusions out of group. We can see this sometimes too. So this MF that you see here, that stands for mixed field. And on the next slide is what we call mixed field. So I'll just show you that slide. So when I was in the lab, if we thought we had a mixed field reaction, the only way you could really see it was under a microscope. We actually used to check our tubes for very weak reactions under a microscope. Don't tend to do it these days. In tube reactions, it is quite tricky to see a mixed field reaction. And most of all, what you see is you'll see some tiny clumps of cells, but then you'll see just a sea of negative cells. So it's like some of the cells are reacting, some of the cells aren't. And as I said, this is most commonly seen post-transfusion. So this is where you've got, you know, a group A person who's been given group O blood. It may in fact dilute the reaction between the A antigen on the patient's red cells and the anti-A in our anti-A anti-sera, because there are group A cells there and there are group O cells there. You have to have a lot of cells for this to happen, but sometimes that does. Sometimes there are situations where a patient may be transfused with 10, 15, 20 packs of red blood cells, and they may be given other solutions as well. So their own blood group can be quite diluted. So that's what a mixed field reaction is. And so remember, weak or missing antigens in the forward reaction is a group 2 discrepancy. Once again, because we're dealing with IgM antibodies here, the best way to deal with it is to cool to 4 degrees. So you can add a bit more anti-sera to it and cool to 4 degrees. The other thing you can do is to wash the cells, because sometimes you can get substances that are interfering with how the red cells interact with the anti-sera. The patient's red cells interact with the anti-sera. The other thing that can occur, and this is really quite unusual, but because you're learning about discrepancies, you need to know about it, and this is something called the acquired B phenomenon. And the acquired B phenomenon occurs in group A individuals, and it usually happens when you've got some sort of a bacterial infection in the digestive tract. So the bacterial enzymes produced by the gut flora can breach the physical barriers of the gut and enter the circulation, and the enzymes actually modify the A antigen so that it now mimics a B antigen. And you can see here that the reaction is a lot less. And so you get this additional weak reaction in your forward group, which is not supported in your reverse group. Okay. Once the infection is gone, then you lose that acquired B. Okay, so there are some other quite rare blood group discrepancies for you to learn about as well. And so chimeras happen when you've got 2 cell populations there. So it's extremely rare, and it's when twins of different blood groups share the umbilical vein, so you get mingling of the different blood groups in vitro between the babies. And it can also happen artificially, so it can happen after blood transfusions or bone marrow stem cell transplant with a different blood group. So there's a couple of ways in which that can happen. And this is where you can get low incidence antigens that can actually react with the reagents, the anti-A and the anti-B reagents. Okay, so very quickly on to group 3 discrepancies, and these are where we have plasma protein abnormalities. And remember, we met these plasma protein abnormalities, some of them in Haematology 2 last year, when we were learning about our plasma cell myelomas. And so that's when, for some reason, we have got increased proteins in the plasmas or abnormal proteins in the plasmas. And they can actually interfere with both the forward group and the reverse group. So what you need to do with those is you need to wash the patient's cells to remove any protein that may be surrounding the cells and causing rouleau or pseudoagglutination. And so that will help with the forward reaction. And what you can do with the reverse reaction, which is really interesting, is if you dilute the patient plasma with buffered normal saline, what that will do is it will spontaneously get rid of the pseudoagglutination or the rouleau, but you should still have enough antibody there in the patient's plasma to react with your reverse cells. This Wharton's jelly is sort of it's a funny sort of a mucosally type compound that is in the cord of babies. And so you need to, when we do a cord blood group, and these are usually babies that are born to RHD negative mothers, so we're just checking to make sure that they are not RHD positive. Or that there's an ABO mismatch for that reason. So we need to make sure that we can group the baby, and you need to get rid of this funny jelly-like substance which is present in the cord blood, because it will interfere with the blood group. The way you do that is you wash the patient's cells. And finally, we've got our group 4 discrepancies, and this is all of our miscellaneous discrepancies, so anything that we can't put in another group. And these include polyagglutination, which may, so that's spontaneous agglutination, and that just may be, it looks like agglutination, but it's not. We have a number of other cold reactive antibodies that you'll learn about in the weeks to come. And remember, we learned about cold agglutinin disease last semester, didn't we? So they can interfere with our blood group reactions too. Post-transfusion of group compatible blood, but not group specific blood. Again, we can get our mixed field reactions. So we talked about that before. And this is where, remember, we talked about anti-A1 that can be made in some A2 individuals. And so we can get that down here. So this is what you're showing. This is what happens. So the A2 individual has got A antigen only on their cells, which reacts with our anti-A, but in about 2 to 8% of those people, they can form an anti-A1. And so we get this discrepancy in our reverse reaction with the anti-A1 in the patient's plasma reacting with A1 cells. And this is the only way we can tell that we have a group A2 patient if they have formed an anti-A1, because this is what we see in the reverse group. Okay, so going through those each in turn, going through the polyagglutination, the cold autoantibodies, the anti-A1. You do need to know how to resolve the anti-A1 to make sure that you've got an A2 individual, because it's very important to identify that as anti-A1, because that can cause hemolysis if it is transfused to an A1 patient. Unexpected alloantibodies, as I said. And again, this is how we do it. So this is our A1 individual compared to our A2 individual and what we find and the results that we get. And here's an A2 with an anti-A1. And that's what we find. Okay, but this here, Dolichos biflorus, and these A2 cells, we don't normally have those in our repertoire. We don't usually test for those. So you can see that if our A2 does not have an anti-A1, they react exactly the same as the group A1. It's only if they have the anti-A1 that we pick it up in the reverse group. Okay, so I've gone 10 minutes over. I do apologise, but you'll just have to tell Melina that Jane went over. Okay. So has anybody got any questions before the people who have got prac dash off? Okay, no questions? You better run away quick. Melina, it was Jane's fault you're late. And I'll stop recording now.